Work Wellness Institute is transforming research into workplace performance and health. As an organization, we function throughout the complete cycle of turning research into practice, mobilizing knowledge as a research institute, community partner, funder, and educational provider. Our mission of creating safe, healthy, and inclusive workplaces for all is our driving motivation. Learning is a lifelong journey to adapt to the forever changing needs of the workplace. Whether you are a leader, a professional, an academic, or a student, we provide high-quality resources that are evidence-based, topical, and relevant to all industries. Choose the Work Wellness Institute as your learning journey partner and become a member to gain full access to our diverse knowledge mobilization programming, including lectures on demand, e-curriculum, 3 distinct certification opportunities, and more. Continue to learn and connect with the Work Wellness Institute and see how we can support transforming research into performance and health for your workplace.
Welcome, everyone. I'm just going to give a moment in that Zoom delay of opening up the webinar today. All right, wonderful. I'm just going to get started to be mindful of time. So we're beginning right at the 10 a.m. for those of us signing in the PT time zone. Thank you so much for joining us today and spending your time with us on this important topic. I would like to officially welcome everyone for joining us in today's webinar on the topic of unpaid caregivers well-being in the context of the Canadian workforce. My name is Elizabeth White, and I am the team lead of Learning and Development with the Work Wellness Institute, and I will be here to help host and moderate today's webinar. I would like to start off by acknowledging that I have the privilege to live and work on the traditional, ancestral, and unceded territory of the Coast Salish peoples, Squamish, Tsleil-Waututh, and Musqueam nations. This webinar is made possible through the support of our funders, partners, as well as memberships to the Work Wellness Institute, and we thank our advisory committees and speakers who contribute to this webinar series. I'll just take a few moments off the top here to go through some housekeeping points. Hopefully at this point you're able to hear me, and shortly you'll be seeing a presentation. So hopefully you're able to hear that through your computer speakers, or if you dialed in today through the conference line. And we do ask that all participants stay muted throughout the presentation. You will see the option for a CC function if that is the closed captions, if they are needed for you. And if you're not seeing that, please feel free to go through the chat, or we might be able to just put that function on as soon as we finish up this introduction. There's also, just to point out, a couple of different ways to communicate with us in today's webinar, both of which would be found at that bottom tool functions menu that we're most likely all very familiar with at this time. So if you are experiencing any kind of technical difficulties, or you would like to share a thought or comment with the group today, please utilize the chat function, and you'll see that chat function pop up shortly, as we will drop an FAQ sheet in there that helps with those kind of initial technical or maybe logistical questions you have around today's webinar. We will also have a dedicated question and answer period through this webinar, and you'll also see a Q&A specific function in that toolbox, and that's where it's best if you're able to send through your questions there. It does provide some more options around anonymity or directly communicating with the administrators of this webinar, so that's a great function to utilize when we get to that Q&A portion of the end of today's presentation. But please do not hesitate to hold your questions. You can submit them as the conversation and presentation goes on today, and we'll be sure to gather them all for the dedicated question and answer period. If any questions are coming to mind about what happens post this webinar, I'll just address those quickly now. All registrants and attendees of today's webinar will be emailed the link to our eCampus, where this recording will be housed post this session. And for Work Wellness Institute members, that will be automatic access gained there. And it's also available for individual purpose for those that are perhaps non-members. As well, if we do run out of time today, as we like to be punctual with the hour that we've dedicated, we will prepare the question and answers that maybe we didn't get to, if that does happen today, and we'll send those along as well. And a final reminder to the Work Wellness Institute members, you will receive an automatic certificate of attendance for being here today. Thank you for indulging all of those housekeeping, and I'm excited to transition into the main event today. And we're very excited to have Husayn Marani with us today, PhD, and his specialty is health services researcher with an interest in healthcare policy, older adult care with a specific focus on dementia care, and the organization of human resources in home and facility-based long-term care. He is currently a decision scientist at Ontario Health, where he supports mixed methods of evaluation of models of care, and he also teaches a variety of courses in the areas of gerontology, community care, and health policy. Thank you so much for being with us today, and I'm very happy to pass things over to you.
Thank you, Elizabeth, for that warm introduction, and it's a great privilege to be here. I'm just going to pull up my slides. So hopefully you can see this right now. So just by way of reintroduction, my name is Husayn Marani. I am a PhD trained health services researcher with expertise across a variety of areas, particularly health policy, community care, gerontology, and aging. And my doctoral research focused on unpaid care in the home care context. So I was particularly interested in understanding some of the challenges, particularly the financial challenges associated with caring for somebody living with dementia at home. As Elizabeth mentioned, I teach across this area. I have, lived experience in this area. I work in this area. So I come to this presentation with a variety of experiences and expertise, but I also recognize that I may potentially have some gaps in my knowledge. So I'll hopefully reserve about 10 to 15 minutes at the end of this discussion for an open Q&A and an open discussion about some of the topics that we discussed today. So with that, I'll just jump into my first slide. I first and foremost want to recognize that I speak to you from Toronto, and in the Mohawk language that refers to where there are trees standing in the water. Toronto is on the traditional land of the Huron-Wendat, the Anishinaabe, the Haudenosaunee, and the Seneca, and most recently the Mississaugas of the Credit River. And today, this meeting place is still the home to many Indigenous people across Turtle Island. And I want to acknowledge that I'm grateful to have the opportunity to live, to learn, and to work on this land. I also want to acknowledge that I have no conflicts of interest to declare. So I want to have a bit of, just present a quick outline on what we'll talk about today. And again, the purpose of this presentation is to share my general insights and experience around the area of unpaid caregiving in the context, sorry about that. Unpaid caregiving in the context of the workplace and the corresponding public policy interventions or supports that would be needed to enhance the ability of unpaid caregivers to continue working as they provide care, or to freely and unreservedly take time off to provide care. So as Elizabeth mentioned, we'll reserve Q&A to the end. Feel free to post the questions or comments that you may have throughout this presentation in the chat box. If there's something particularly pressing that you want me to address, Elizabeth will interrupt me and will flag that for my attention. So first and foremost, I'll situate our understanding into what unpaid caregiving is. How do we define unpaid caregiving? We'll talk a little bit about some trends around unpaid caregiving and their corresponding policy relevance. I'll bring in some of my own research, empirical research, by providing some evidence from Ontario. We'll discuss some policy levers, some approaches to protecting unpaid caregivers in the workplace, and then we'll wrap up with some conclusions. So first and foremost, let's define an unpaid caregiver. So an unpaid caregiver could be a family member, a friend, a neighbor who provides care on a long or short-term basis, on an unpaid basis. And the jury is still out in terms of how to define what long-term or short-term care means. When we talk about long-term, typically it's a time-based metric. So it's usually above 3 months, but it could be above 6 months. It could be beyond a year. Usually the care is provided for somebody who lives with a chronic illness. So care is long-term in nature. Short-term care might be provided on a shorter term basis, again, relying on that time-based metric, usually less than 3 months, but it could also be less than a year. And again, usually this care is provided to somebody living with an acute condition, or perhaps they may be living with an injury that requires short-term rehabilitation, or they may be requiring end-of-life care where death is imminent within the next 3 to, let's say, 12 months. But again, um, quite an arbitrary term, and the jury is still out in terms of how to define long versus short-term care. The care that's provided, when we talk about unpaid care, it's usually providing care for those who require support with their activities of daily living. So these are downstream services. They are support for things like grooming, feeding, dressing, bathing, toileting, and transferring. So lifting somebody out of a bed or onto a wheelchair or into a shower, for example. But it can also constitute care, providing support for instrumental activities of daily living. So for example, meal preparation, medication management, banking, transportation to and from a medical appointment, laundry, home maintenance, technology use. And there's often a misconception that, although these are not explicitly types of health or medical care, that this undermines the skill of an unpaid caregiver. In reality, we're increasingly understanding that unpaid caregiving requires skill. It's a very skills-based activity in the sense that unpaid caregivers often have a unique relationship with their care recipient that, say, a paid healthcare worker would not have, that enhances the ability of the quality of life of that recipient receiving their care. And we'll talk about this specific nuance when we talk about terminology on the next slide. So again, a care recipient may be living with a health condition. It could be chronic or acute. They could be living with an injury that requires long or short-term rehabilitation, or they may be living with an age-related decline. And this is obviously not an exhaustive list. It is not a mutually exclusive list. In fact, we know that those with the highest intensity care needs tend to be living with both a chronic or multiple chronic conditions combined with, say, age-related decline. So the experiences of unpaid caregivers tend to not be homogeneous. They're quite diverse, which makes identifying support needs, whether that's in a workplace setting or otherwise, quite challenging, as well as the organization of supports that they require at the public policy level. And I'll talk about this a little bit more later, but the vast majority of unpaid caregivers provide care for somebody living at home. But it's important to recognize that we do see unpaid caregivers across a variety of settings, including facility-based long-term care and even within hospitals, depending on how long a care recipient is staying within a hospital setting. Unlike paid caregivers, those who are compensated for their work, for their labor, unpaid caregivers tend to perform these care activities on a personal basis. So it's usually driven by a personal desire. It could be driven by their care recipient's needs or preferences. So for example, they don't want a stranger taking care of them. And we see this in the context of, advanced dementia in particular. It could be rooted in tradition. So a lot of ethnocultural groups, for example, provide care on a personal basis, and that's driven by filial piety. And we also see tradition as far as enduring gender roles. The vast majority of caregivers tend to be female, and accordingly, it's important to understand or look at caregiving through a critical feminist lens. We also see caregivers providing care as a result of a familial obligation, or the absence of aid from other people. For example, home health aides, personal support workers, as we call them in Ontario, as well as institutions such as policy itself that can enhance the ability for unpaid caregivers to provide care. So in the absence of these supports, we see unpaid caregivers taking on this role on a personal basis. So as I mentioned previously, we have to be cognizant of the fact that unpaid caregivers provide care on a personal basis. And there's a lot of scholarship emerging on how to define paid versus unpaid care. In this context, I will refer to unpaid caregivers as such, but it's important to recognize that you may see in the literature unpaid caregivers being referred to as family caregivers or less optimally formal caregivers. To my point earlier about unpaid caregiving being a very skilled role, there's nothing informal about the care that unpaid caregivers provide. So, you will see in the literature, you will see in reports, you will see in media articles, these terms such as informal caregiver being used to describe those who provide care on a personal basis, and formal caregiver being used to describe those who provide care on a compensated basis being used. But one of the takeaways from this is for us to collectively strive to use more inclusive language. So in the context of providing care on a personal basis, using the term unpaid caregiver, and providing care on a compensated basis, using the term home care worker or healthcare professional or paid caregiver. So let's move on now. I want to sort of situate our understanding now in the sort of trends around unpaid caregiving. So we know that across Canada, based on StatsCan estimates, that there are about 7.8 million unpaid caregivers in Canada. That represents around 1 in 4 Canadians above the age of 15. This is a fairly, at this point, outdated estimate, I would say. Even though it's within the past 5 years, we expect that this is a number that will increase. The data is derived from, of course, census data, and there is a module in the Canadian Census on caregiving that's conducted every 5 years. So I anticipate we'll have an updated understanding of this specific estimate in a few months from now. But for now, just appreciate that there are a lot of unpaid caregivers across Canada, and the terminology that StatsCan uses is quite it's quite broad. So, this can represent somebody providing care for somebody for maybe like less than an hour a week, but still for, from that perspective, that constitutes care. So we have to be cognizant of who is represented in this statistic. And we know that as a result, we expect this amount, as a result of the changing conditions under which caregivers operate, that this statistic will increase. And some of those conditions have been mapped out. We know specifically that shifting patterns of care has important implications on the growing responsibilities among unpaid caregivers. So we know, for example, that care is increasingly moving towards the home care context. This is spurred by, strategies across provinces and territories, like in Ontario, aging at home, in BC, aging in place, that improve the capacity for care to be provided at home as opposed to a residential long-term care facility or nursing home. In Ontario, for example, again, most of my evidence will be coming from Ontario, but it's fairly generalizable across across Canada. But in Ontario, we know that about 83% of Ontario's 3.3 million caregivers provide care for somebody living at home. And a lot of the strategies that have emerged in recent years to enhance home care have been spurred in part by economic incentives. So generally speaking, home care is less expensive to the public health system than, say, hospital-based or publicly funded long-term, facility-based long-term care. And that's part and parcel because home care is considered an extended service. So it's not part of the basket of publicly covered or subsidized services under Medicare as stipulated by the Canada Health Act. But we do know that many provinces and territories do subsidize a vast majority of home care services, but they are subsidized to an extent. So there are usually caps involved, after which we see the responsibility being either the care recipients or the caregivers to pay for some of those expenses. We also know that the proportion of healthcare expenditure, at least in Ontario, that's attributable to publicly funded long-term care is about 7%. So, and that's that accounts for about 115,000 people. So, that's a significant number of public health dollars that goes towards long-term care. And it's natural that we would expect to see policy approaches try to shift that cost elsewhere to a more cost-effective area. And in this case, that tends to be the home. But the question is, who are those costs then being imposed upon? We also know, our population is aging. Improvements in health and life expectancy mean that people are surviving well into advanced older adulthood. And with that, they are, of course, experiencing a higher number of morbidities that need to be managed and accordingly have a greater intensity of needs, of care needs. This is coupled with, our changing demographics. We are very privileged to be in a country that welcomes newcomers, and increasingly we're seeing a larger percentage of newcomers among older adults who need those those care services as well. So this is another example of why we're seeing the changes in the conditions under which unpaid caregivers operate. Related to this, we're seeing gaps in the supply of human resources. In short, there's a significant demand now for those who are paid to provide those downstream services, those supports, those home-based supports for activities of daily living. Here I'm talking about, those home health aides or those personal support workers. Many home care workers are also leaving the workforce. There are care continuity issues. There's a lot of turnover among paid home care workers. There's a lot of, although publicly funded home care is, or rather, although home care is publicly funded, again, it's funded to an extent. So there are still deficits as far as availability of home care is concerned when those deficits, when those hours, for example, of home care have been exceeded and unpaid caregivers need to fill those gaps out of their own pocket. And we also see a lack of training, particularly in the context of older adult or advanced dementia care among home care workers, which again increases the role and responsibility among unpaid caregivers who have that intimate knowledge about their care recipients' needs. Wait lists are also increasing for residential long-term care, which again is putting a greater burden on unpaid caregivers to fill those gaps at home. And COVID-19, my research has shown that a lot of safety concerns that were spurred by COVID-19, particularly as they relate to the transmission of COVID-19 among long-term care facilities and between homes that personal support workers work in, encouraged unpaid caregivers to take on that care role themselves to prevent transmission. So a variety of conditions now that we're seeing changing the landscape of unpaid caregiving, and in particular, the context in which caregivers work. Most of our understanding of unpaid caregiving is based on the home care context, where we see most of the highest proportion of unpaid caregivers. We know that across Canada, 96% of individuals receiving long-term home care have an unpaid caregiver. In the Ontario context, we know that about 3.3 million unpaid caregivers, 83% of those 3.3 million unpaid caregivers provide care for someone living at home. We also know that 91% of older adults, particularly Canada-wide, would prefer to remain at home if additional supports were available. And this term supports is quite broad, but it encompasses greater supports for their family members or loved ones who would be able to provide them that care at home. And when we talk about home care, we're specifically referring to professional or those paid home care services. So our understanding of home care typically excludes care provided by family members or friends, which allow people of all ages to receive care at home rather than in a hospital or long-term care facility. Home care services include short-term care for recovery, long-term care for disabilities, chronic conditions or age limitations, and again, end-of-life care. The evolving conditions that I previously described under which unpaid caregivers operate are calling into question the sustainability of unpaid caregiving without an infrastructure of these supports. And we know through the literature, through a large body of literature actually, that there are a number of challenges that unpaid caregivers experience. This is not an exhaustive list by any means. And again, these challenges are not mutually exclusive. One of the most important, I would say, challenges is the emotional distress of caregiving. And this is characterized by feelings of anger and distress. We know that based on CIHI estimates that approximately 1 in 3 unpaid caregivers is distressed. Those who experience this level of distress tend to provide over 38 hours of care per week. That's equivalent to a full-time job. And this is twice the number of hours that caregivers who are not distressed experience. And of course, this has immense implications on workforce participation and the ability to take care of oneself. We also know that distress is not experienced equally among caregivers. Caregiving, the population of caregivers is a very heterogeneous population. And so the experience of distress tends to be mediated by factors such as geography, the experience of providing care in a rural versus an urban environment is very different on the basis of access to resources. Again, it differs on the basis of age, on the basis of gender, on the basis of self-rated health status, on the basis of the care recipient's health status. So for example, older adults with advanced dementia or cognitive impairment tend to have higher intensity care needs, which have greater implications on their care recipients' emotional distress. We also see emotional distress mediated by the extent of service utilization. So for example, hospital stays, the availability of respite care, home care visits, and the availability of support from family members. Other challenges include physical challenges due to age or injury, health system barriers, the ability to, the challenges associated with navigating a health system, translating on the for care recipients, advocacy constraints, being recognized as an essential part of a care recipient's team by the health system. And my area of research, which is around the financial challenges, so what we call financial risk across domains such as employment, income generating potential, and personal health. So the ability to pay for your own personal health costs. So I want to focus on this because this is where this is sort of the area of my expertise, the financial risks of caregiving. And when we talk about this term financial risk, we are referring to the consequences of direct private or out-of-pocket healthcare expenditure, which includes both the magnitude of out-of-pocket expenditure and the impacts of these expenses across domains of financial risk, again, including income generating potential, workplace productivity, and overall personal health. Some of these expenses can include things like paying for a home care worker, home renovations, meals, transportation, so gas. These are expenses that we don't often associate with health or medical care per se, but at the end of the day are part and parcel the responsibility of unpaid caregivers. And there's an increasing importance in understanding financial risks of unpaid caregiving. Again, as I mentioned, from a policy perspective, shifting the costs of the provision of care from, say, long-term care facilities, most of which across Canada tend to have a substantive, subsidization from public, they're publicly funded, that shift from publicly funded care to an extended service in the home care context tends to represent what we call passive privatization. So it could represent, shifting costs from government responsibility to the individual. And in this case, those costs tend to be borne by unpaid caregivers. It also begs the question, who bears these expenses? It has important implications on workplace productivity, the economic implications, which I'll talk about at the end, concerning leaving the workplace to take on these caregiving roles is quite important to understand. And also, that unpaid caregivers are increasingly becoming high-cost users of the health system. And by high cost, I mean the smallest number of our healthcare users accounting for the largest proportion of healthcare costs and overall health system utilization. So this is, there's a lot of policy relevance around understanding the financial risks of caregiving. But we know very little still around some of the implications of these risks, of particularly this expenditure across domains such as income generating potential, employment, and personal health. So this is where I tried to fill some gaps. So I conducted in Ontario a mixed method study involving a survey and an interview to understand the financial risks of unpaid caregiving. And this was conducted during the peak of the COVID-19 pandemic. So the findings are sort of situated in the COVID-19 context, but it's reasonable to assume that the findings are relevant beyond the context of the most salient issues that were experienced during the peak of the COVID-19 days. So as far as methods are concerned, I won't get into the nitty and gritty of this, but I conducted a retrospective survey. So looking back in time. So looking back in the past 3 months, what were some of the expenses caregivers incurred in their caregiving responsibilities, and what are some of the consequences? So this was represented across a 72-item cross-sectional retrospective survey. It was completely online. There were 190 caregivers who participated. It was participants rather had to be Ontario-based, unpaid caregivers, 16 years of age or older, English speaking, and providing care for persons living at home. There's an impetus to expand this survey across Canada. If you're curious about the design of the survey and the findings of this particular survey, they have been published. So I'm happy to, I'll have my contact information at the end of this presentation if you want to get in touch about those findings. But generally speaking, the findings were described or analyzed descriptively with a combination of non-parametric testing. And as far as the results, unsurprisingly, the mean age, the average age of participants was around 58. Again, unsurprisingly, 88% were female, 50% were working at the time, so they were employed in the formal labor market, and around 52% around 52 hours of care per week was provided. That's, and that excludes outliers. That's quite a substantial amount of time providing care per week. Top care activities include transportation, navigating the healthcare system, household maintenance, and banking and financing. So a combination of those upstream and downstream services, or those activities of daily living and those instrumental activities of daily living supports. As far as the care recipient is concerned, their average age was around 65, and again, 55% were female. Their relationship to their caregiver was mostly parent, but we did see representation from child, or them being children or their spouses as well. And their top conditions were things like frailty, dementia, urinary or bowel incontinence, as well as mental illness. As far as their expenses were concerned, by average dollars in the last 3 months, we saw that the highest expense was in the procurement of a home care worker. So somebody to help take on some of those responsibilities in providing care or supports for those activities of daily living. Other expenses included home upgrades or renovations, and then medical equipment as well. So wheelchairs, Hoyer lifts, things of that nature. And one of the important or salient findings was around, paying out of pocket for a home care worker, for example, a personal support worker, was associated with a decrease in paid home care availability during the pandemic. So unsurprisingly, as a result of restrictions on the movement of personal support workers between homes or long-term care facilities, as a result of concerns around transmission of COVID, attributable to this movement among personal support workers. And of course, in terms of the supply issues among personal support workers during this time, many many unpaid caregivers at home had to pay out of pocket for additional home care services. And so we saw that increase during the pandemic. As far as salient results are concerned, when we look specifically at income generating potential or income in general, caregivers saw their income decrease during the pandemic. So approximately 32% saw their income decrease during the pandemic, and approximately 46% saw their weekly care expenses increase during the pandemic. And figure 1 on your screen shows that there were greater difficulties paying for these care expenses during the pandemic relative to before. As far as personal health is concerned, the vast majority of caregivers desired greater public financial support. So this is a very broad term. This could mean, of course, compensating them for their role, subsidizing some of the expenses that they incurred, as well as employment-based supports as well. So, allowing them to take time off to provide this care. We also saw about 47% of caregivers desiring more support from a home care worker. As far as workplace productivity is concerned, this is sort of the bulk of what my research findings demonstrated. Around 55% of caregivers reported a change to their employment sometime during the past due to caregiving. So either they retired voluntarily or involuntarily, or by involuntarily, I mean they were laid off, or they reduced their weekly working hours, or they lost or quit their job, which was associated with a loss in workplace benefits. Around 78% of working caregivers had to modify their work schedule to provide care. So this involved starting late or leaving early or taking time off during the day. And this occurred approximately 14 times over the past 3 months. And this is an important context to consider when, most of us who receive employment benefits tend to qualify for maybe 2 personal days per year. And we're talking about having to take time off almost 14 times over the past 3 months. And this is not necessarily pandemic related. And 40% of working caregivers predicted that they would have to modify their retirement plan. So over 31% now retiring later, and 9% now retiring sooner. And we saw, in this research that more caregivers ended up retiring or becoming unemployed during the pandemic than before. So this could be associated with, again, that increasing prevalence to take on caregiving roles as a result of that gap in the availability of paid home care workers. As a sort of follow-up to this, this quantitative work, I discussed these findings with 24 caregivers who provide care in the context of dementia in particular. So 24 home-based dementia caregivers. And I was curious to understand how they navigate publicly funded home care, particularly with an emphasis on that acquisition of a paid home care worker. And there were a lot of challenges around navigating supports. So, they experienced challenges learning about publicly funded home care. So the availability of support from a home care worker. There were a lot of challenges around requesting and obtaining support from a home care worker, specifically a PSW in the Ontario context. And I think most notably, there was a challenge in maintaining access to publicly funded support from a home care worker. And this challenge in maintaining support had implications on their workplace productivity. So they had to take time off work because they couldn't maintain access to a home care worker who was publicly subsidized. So they couldn't pay for it themselves. So they had to take time off work to take on that role. Or they could pay for it, but they were unable to, they were unable to find a home care worker at the time, given those supply issues. So some of these, when we talk about, this is one of the earlier few studies, I would say, that look at the financial risks of unpaid caregiving and their implications on domains, with a specific emphasis on workplace as a domain of financial risk, or employment rather. But a lot of work has been done out of the University of Alberta by Eels et al. Around the labor force participation rates among unpaid caregivers and their contributions as a whole to overall GDP and the workplace. So we know that 5.7 billion hours is the amount of unpaid care that's spent among unpaid caregivers, which reduces opportunities for education and employment, connecting with family and friends, and maintaining caregivers' overall well-being. If we quantify this monetarily, this represents approximately $97.1 billion, which I like to say is what the unpaid caregivers contribute as far as their unpaid labor is concerned to the health system. So our health system has saved this much as a result of unpaid caregivers taking on this role, which begs the question, in my opinion, around how much support do we actually now provide unpaid caregivers given their societal contributions. And we know, of course, that based on these estimates, this is accounting for about 2.8 million full-time equivalent workers. When we now look at policy levers to support unpaid caregivers, so this is where we get a little bit theoretical, and I'm not going to get into this too much. This is sort of where my interests or theoretical interests lie. We can understand how to support caregivers through the lens of the welfare state. So the welfare state, very, very, very simply put, is a conceptual framework that helps us understand how social benefits are distributed across members of society. So, in my analyses and I sort of propose 4 buckets around how to support unpaid caregivers in terms of compensating for their time spent caregiving, in terms of compensating their care-related expenses, in terms of how much publicly funded home care is provided, and in terms of whether or not there is publicly funded care leave if they are employed in the formal labor market. So in the Canadian context, we tend to have in the context of unpaid caregiving, a fairly liberal welfare state. Care is largely a family responsibility. Care support, public care support in particular, is based on supply and individual need. So it tends to target caregivers and/or care recipients with the greatest need, where the quantity of support is determined on the basis of a financial test. So that could be a means test, for example, or a needs assessment. And the provision of care leave would typically be reserved for those who are unable to participate in the labor market. So in this case, the discretion is on the basis of the employers themselves to provide additional care leave if necessary. And grounded in the sort of theoretical perspective, I argue that, little policy attention is paid to supporting unpaid caregivers. And we saw this, as soon as the Canada Health Act was passed, there's very little emphasis on supporting unpaid caregivers. We had a landmark Canadian Senate report in June of 2000 called The Quality End of Life Care, the Right of Every Canadian, which called for income security and job protection for family members caring for somebody who is ill or imminently dying. And this spurred what we now call the Compassionate Care Benefit, which is an employment insurance-based benefit, in January 2004. But again, this is largely focused on those who are providing that end-of-life care, and it's for a very brief period of time. It doesn't really consider long-term care, again, that care that exceeds perhaps 3, 6 months, or 12 months. But then we did start to see greater supports emerge across provinces through aging at home or aging in place strategies. For example, in Ontario, we saw in 2006 local health integration networks, which have now undergone a kind of reform, which I won't get into, but embedded in these this network of community care, region-based community care services, was a greater emphasis on providing care supports. But still, we see most supports existing at the federal level, and most supports being largely income security based. So they target those who are working. And as a result, my research has shown that many caregivers, particularly those who are retired, see really no benefit in these supports. Those who are working but who are under a certain threshold of income also see very little benefit of these types of supports. And when you look at the monetary value of these supports, they're quite limited. So we do need an improved understanding of how unpaid caregivers navigate the workplace and the care-related challenges that might prohibit their workplace productivity. When we think about supports, be it public supports or employer-based supports, the goal really should be to minimize caregiver distress, either by giving working caregivers an opportunity to take an extended period of time off, or alleviating caregiving responsibilities so that caregivers can continue working should they want to continue working. And a lot of policy interventions have now been explored. For example, in Nova Scotia, we can see the emergence of a pilot test that looks at cash for care benefits. So giving caregivers a non-mean tested benefit, a certain amount of cash that they can use towards anything, including compensating themselves for their care. National long-term care insurance, very similar to what we see as a pooling of resources, of tax-based resources, or a supplemental insurance to that caregivers can dip into when needed. That emphasizes a kind of social solidarity, as well as lifting service maximums for home-based long-term care services. So for example, in Ontario and many other provinces, there are caps on the number of hours of publicly funded personal support work caregivers qualify for. And so one option now is to lift those maximums, but this of course depends on the availability of those healthcare workers if needed. So there's a lot of work to be done in this area. I'm trying to, of course, make my little mark in this area, but it's going to be a bit of a long haul to get, to see progress. Again, given the nature of unpaid caregiving, diverse needs, and of course, how many caregivers we expect to see as Canada's population ages and expands. So with that, I thank you for your time. If you have any questions, my contact information is below, and I'm happy to address any questions.
Thank you so much for sharing your expertise with us and kind of providing some insights into perhaps a demographic that not everyone has this time to get to know in such a detailed way. So thank you so much for that. I'll just provide a quick reminder to our audience today. We have the chat box open and available for you, as well as the Q&A chat box, both of which will communicate with us directly for any questions that you may have. But I'm going to start off with the first question around the kind of the role of the employer and how can someone even perhaps start this conversation if they are needing some extra supports, or their situation is becoming more demanding outside of work, those kinds of things. And how can we get the employer to become a part of the solution and become a part of the conversation with the individual that may need those extra supports?
Yeah, and it's a very good question that I think demands a bit of a cultural shift in our understanding of caregiving. And this is where I believe this presentation might come in handy, because we really don't have we have a very bird's eye view of the nature of unpaid caregiving, but it still seems to be a very taboo topic in the employment-based context. And so I think breaking down those barriers, talking about unpaid caregiving, those challenges needs to be sort of the first step to normalize this discussion, because we do see, large emphasis on child care, but not the same emphasis on older adult care or disability related care. So I think the first step is really to break down those cultural barriers and have that conversation with an employer at first.
That's a great cultural shift that we might all need to strive towards. Where perhaps do you see the role of accommodation coming into play? There is some kind of structure around accommodation, but perhaps
Mhm.
the caregiver themselves might not fall under these. However, you did in the earlier part of the presentation show that perhaps they themselves will fall under perhaps some kind of disability or things like that themselves around
Right.
mental health or physical health. So where do you see the role of accommodation coming into play in this conversation to hopefully try and prevent coming into those more formal needs?
Yeah, I think so. Right now, existing accommodations are based on a very narrow definition. And I think, as we talked about in this presentation, the needs of caregivers and their care recipients is very diverse. It's a very heterogeneous group. And so I think first and foremost is expanding that definition of accommodation so that it fulfills a broader basket, a broader bucket really of care needs, as well as the demands of caregivers. Because I think right now, even when our understanding of disability-based benefits, that disability tax credit, for example, that care recipients, and by virtue their care recipients qualify for, is a very narrow definition of disability. So I think first and foremost is to critically think about what qualifies the definition of accommodation, and then expanding that so it's more encompassing and more inclusive.
Absolutely. And again, touching on that cultural shift, right? That would demand that as well to even allow for that opening of definition, I
Mhm.
imagine. So when we're looking at, we did talk a bit about the COVID-19 pandemic and perhaps some how that may have affected. One of the things that came out of that was perhaps working from home options, hybrid work, those a bit more flexible. Just wanted to speak to that. Is that a solution that you see as being positive or you saw was positive through the interviews?
Yeah, oh, 100%. Through my interviews, and I'm glad you touched on that. There was a resounding emphasis on that work from home environment as facilitating care, the ability or enhancing the ability of caregivers to provide care. And, I think that really is the way in which we're going to see workplaces moving forward. It's clearly emphasized that we as a workforce can be much more productive at home. And as far as even childcare is concerned, balancing both childcare and employee and being and working it has been enhanced through the possibility of working from home. So I think it is an important goal to figure out how to maintain that work from home option as long as possible.
Yeah, absolutely. And it also touches a bit on the accommodating and thinking maybe a bit more broadly on, not being so constrained to those narrow
Yeah.
definitions of what accommodations look like. So we have some questions around some of the demographics that you brought forward earlier in the presentation.
Mhm.
And just wondering, from the different demographics, was there any emphasis or questions around differentiations of experience of unpaid caregivers through different lenses? Can you speak to that at
Yeah.
all?
I think this is one of the biggest limitations in the vast majority of caregiver research. And one area that's close to my heart is representation of caregivers from different ethnocultural backgrounds.
Mhm.
My research, because it was conducted during the COVID-19 pandemic, relied a lot on convenient sampling. So, a recruiting based on in context that's most convenient. So social media was primarily the platform from which I recruited participants. That meant that caregivers had to have access to the internet. It meant that caregivers were able to read and understand the English language. It meant that caregivers interpreted the roles that they were doing as caregiving. But when we, again, drawing upon my own personal experience, some of my own roles, I don't identify as caregiving. And we see this particularly across different ethnocultural backgrounds. And so I think that's where we see an opportunity in this research for more improvement, is to garner more engagement among caregivers, not only from different ethnocultural backgrounds, but from different populations across Canada, rural and urban, among those who are providing care across different types of for different services, and for different needs, chronic conditions in particular. There's a lot of diversity in care needs. So I think that's an area that we need to further improve upon.
I think that's such an interesting point to bring forward, that those that we might consider, from certainly a research perspective, unpaid caregivers, they don't actually identify that as
Exactly.
themselves, whether that's just because of cultural or just their own personal views of course I would do that. Why would I consider myself an unpaid
Yeah.
caregiver? So that's an interesting point to think about when kind of moving forward with this
And
discussion.
and just to add, sorry to interrupt, one of
No.
the most important findings I thought from this work, one of the questions I asked caregivers was, do you want to be compensated for your unpaid
Mm.
labor? And most caregivers, I would say with the exception of two, said absolutely not. I don't want to be paid for this work, even though they identify their caregiving as work, right? So it was a kind of interesting finding there, because it's clear that they see it as labor, they see it as a kind of work, but they don't feel that they should be compensated. And if they were to be offered money for it, they don't want to be paid for it. So again, it brings but yet they need supports, they need that help. So what does support look like? And I think that's again an opportunity to target some of public policy support and employment-based support.
Well, that's another good nugget to really point out. I'm glad we were able to bring that point forward, because I think
Mhm.
that's a really interesting area of conversation. And just to wrap it up, as I see we're only at a couple minutes left here, I know your particular research was done in kind of the peak, as you mentioned, of COVID-19, but
Mhm.
so just wanting to discuss, in the research you might have done previously or looking future, what do you see as the future? Like, how much did the COVID-19 pandemic maybe bring differences to this discussion, or do you see moving forward that these are the challenges that will remain?
No, I think the COVID-19 pandemic fundamentally changed, the provision of healthcare across the board. I think that at the end of the day, what the care needs that I think caregivers require to enhance their ability to provide care, particularly at home, will be important to consider even beyond the COVID-19 pandemic, which of course continues to exist. I would argue that, one of the lingering effects of COVID-19, which make the findings of this research, generalizable for years to come, are those supply issues as far as paid home care work. And so I think that that's the target of policy initiatives and even employment-based initiatives, is to recognize that there is a huge gap in that physical human labor, human resource capacity in the healthcare context to alleviate that care burden on caregivers. And so that's really where I see, these findings holding true for years to come.
Okay, thank you very much for your time today and for bringing all of these wonderful different nuances and layers to this conversation that might not have been thought of, or certainly some new things to my mind in thinking about unpaid caregivers and what the future can look like. And hopefully, this conversation can continue to find these different supports and really try and close that gap and provide the supports that are needed for both the recipients of the care and the caregivers themselves. So thank you so much for your time today and this conversation.
Thanks for the opportunity.
Wonderful. So just before we wrap up here today, just a couple of reminders. So yes, this presentation has been recorded and we will post this through our eCampus. Again, all of this will be emailed to our registrants, so you have access to where to go. Again, Work Wellness Institute members, you'll gain that access directly, and there's also options for individual purchase. For our Work Wellness Institute members, there will be a free certificate of attendance just automatically presented to you. If any issues arise because of that, please don't hesitate to reach out to our membership services team at membershipservices@workwellnessinstitute.org. And if the fact that I've called out members and memberships throughout this presentation and housekeeping notes has perked your ear and you're interested in becoming a member, please do not hesitate to visit our website at workwellnessinstitute.org. There's a button right on the homepage of Become a Member that will provide all of the answers that you might be thinking about in terms of becoming a member. It's a very simple system. You could even sign up today if you so chose. But again, any additional questions around that, please refer to membershipservices@workwellnessinstitute.org. I would like to point out that as soon as we close our session today, you will be directed to an evaluation survey. We do very much appreciate you taking those quick couple of minutes at the end to fill that out, as we really do take those quite seriously and ensure that we are looking at them very regularly to ensure that the programming we are providing is relevant to our audience. So your opinion really does matter, and we very much appreciate you taking the time to fill that out. If you are looking to learn more about us or to see what other programming we have to offer, please visit the courses section and resources section of our website. And that is where you'll see everything that is upcoming, as well as everything that we already have to offer. And I would invite you to join us in our next webinar program, which will be on the August 29th at 9 a.m. for those in Pacific time zone and 12 p.m. for the Eastern time zone. And that webinar is on long COVID and return to work with Dr. Jennifer Lunt. So thank you again to our audience for joining us today. We so very much appreciate you taking the time to be with us today and spend your very precious time with us. And thank you, Husayn, again for your time and expertise in sharing that with our audience. And with that, I will close for today. And thank you again all for being here.
Continue to learn and connect with the Work Wellness Institute and see how we're transforming research into workplace performance and health at www.workwellnessinstitute.org.